Assalamu alaikum wa rahmatullahi wa barakatuh. Good evenings, everyone. Thank you for that warm introduction. I feel tremendously honored to be the speaker today. The presentation today is about biomarkers in rheumatology. It will be an introductory presentation. I will not speak about each single rheumatology labs today. This presentation is actually is intended for general practitioner and junior rheumatologist. The content of my presentations are as the follow. The use of biomarker in the practice of rheumatology, understand some basic statistical concepts like specificity of the test, sensitivity of test, or an accuracy of the test. I will go over some most commonly used tests by the general practitioner. The bottom line objective of my presentation today is to understand which labs result may constitute the need for more urgent referral to the rheumatology clinic. So, what are biomarkers? Biomarker is something that we can measure, is a measurable indicator for assessing the risk for the presence of the disease, measuring the presence of some disease state, the severity of the disease, or response to the therapeutic intervention. Those indicator or biomarker could be a descriptive biomarkers like imaging, acute phase reaction lab test, or mechanistic biomarker. Those biomarkers are related to the pathophysiology of the disease like autoantibody, cytokine level, and genotypes. I think all of us, once we hear the term biomarkers, what crosses in our mind is the blood test. But biomarkers could be an imaging biomarker, clinical biomarker, or molecular biomarkers. And as I said, my webinars today will be an introductory lecture to the molecular biomarkers. Imaging biomarker is non-invasive. Clinical biomarker is a physical variable like a joint count, pain score, or symptoms. And we will have in the near futures a lecture to talk about the radiology of in rheumatology practice, and two of my colleagues will give us a lecture about clinical biomarker in two different diseases. So what is the use of biomarkers in rheumatology? The first use of biomarkers is to diagnose the disease at the asymptomatic stage. Silent disease could stay subclinical or asymptomatic until it leads to damage, and this is what we call an occult disease. We always don't start therapy unless the disease is symptomatic. So we need a biomarker that could pick up those proportion of individuals with this occult disease. This will enable early intervention with the ultimate goal of preventing the development of symptoms or at least minimizing the pathological sequelae of the disease. Once the disease is symptomatic, we can use the biomarker to confirm the diagnosis of this symptomatic disease, and also we can use the biomarker to assess the disease activity. For example, rheumatoid factors aid the diagnosis of rheumatoid arthritis, the presence of the ANA facilitates the diagnosis of SLE, JADAS and SLEDAI are clinical biomarkers that are used to measure the disease activity. The third use is to predict responsiveness to therapy. Once the treatment has been started, patient can be either responder or non-responder to therapy. So there is a biomarker that could identify these two groups before the starting of the therapy. This helps to apply the target approach to therapy and reducing exposure if individual unlikely to respond. Another use is to reveal the presence of disease despite the remission of symptoms. Always we stop treatment if the patient is asymptomatic, but those patients could be clinically inactive but yet biologically inactive. So we could use biomarker, as I said, to reveal the presence of biologically active disease despite asymptomatic patient. Why this is important? Because the patient will become symptomatic again and will relapse, with the additional risk of the patient becoming resistant to his original treatment. Another use is the assessment of drug toxicity. For example, biochemical indicator of liver and kidney function. Those are biomolecular biomarker, yani for example, GOT, GBT, kidney function, increased blood pressure, and this is a clinical biomarker, prolongation of QT interval in an ECG, and this is an imaging biomarker. Going forward, a next generation biomarker that can predict an early toxicity or other adverse event for a drug. Another use is current the research in the rheumatology field will allow precise, individualized biochemical indicator of liver and kidney function. A more targeted those are biomolecular biomarker, yani for example, GOT, GBT, kidney function, the treatment increased blood pressure, and this is he could clinical biomarker. Sentence. Prolongation this patient could have a collagen disease in an ECG, and adverse an event for a drug. Order an ANA or rheumatoid factor. It is not the case in our hospital only, but also this is the case or the problem in the developed country also. There is an study done across 3 different states in the United States. A questionnaires sent through an email to the pediatric rheumatologist who are working in different hospitals across those states. The questionnaires or the target of this study was to assess the most common rheumatology tests were ordered, to understand the reason behind ordering them, and to assess the frequency of the unnecessary referral to the rheumatology clinic for positive test result of uncertain significance. And this was the questionnaires. The questionnaire consists of some questions like, have you ever ordered an ANA? Answer yes or no. Have you ever ordered anti-double strand, anti-CCB, rheumatoid factor? And they give the doctor list of possible causes to order this test. The first most common rheumatological lab was ordered is ANA. 91% of the doctor answered yes to the ANA antibody. The next is rheumatoid factor, 73% of the doctor, and 59% have ordered an anti-double strand antibody. And the most common cause of ordering those laboratory tests is for abnormal joint examination. An observation demonstrate that a statistically significant association between the correct utilization of ANA test and the increased year since completion of residency training and the time spent in the rheumatological clinic during residency. The most common reason for referring to the pediatric rheumatology was high suspicion of rheumatic disease. Positive ANA of unclear significance 44%, 14% for positive rheumatoid factor of unclear significance, 9% positive anti-double strand of unclear significance, and 7% for positive HALA B27 of unclear significance, just for a positive result without a good explanation. So, what we conclude that rheumatological lab tests in primary care either in our country or in the developed country, are commonly ordered for incorrect reason. And the problem are these tests are always expensive, false false positive result in unnecessary referral to the rheumatology clinic, put an emotional stress to the patient and their family, may result in significant time and financial burden, as in our case, we are the pediatric rheumatology clinic in Children's Hospital is the only referral clinic in Libya. So we have many cases who came to us from the northern, southern area, and this really could cost the patient time and money. Again, false negative tests can be misleading and cause delayed diagnosis. As I said, the rheumatology labs are non-diagnostic, so we are therefore left with a good primary care physician who always relied on a good history, physical examination, and broad knowledge to confirm or to suspect the diagnosis of a rheumatological disease. Before going over the most commonly used rheumatological labs, I would like to review some most common used statistical terms like sensitivity, specificity, and positive and negative predictive value. We are all familiar with this table. The first column from the left side of the screen represents the all patient who have the disease. Then second column represent the cases who don't have the disease. The first row represent the all positive result using the test. The second row represent all the cases that tested negative. So sensitivity is the percentage of individual with the disease who have a positive result by the test. Specificity, in other hand, is that percentage of individual without the disease and have a negative test result. So sensitivity and specificity are characteristic of the test. Regarding positive predictive value is the probability that a person with positive test who truly have the disease. Negative predictive value is the proportion that person with a negative test result and truly doesn't have the disease. Positive and negative predictive value are related to the prevalence of the disease and affected by the prevalence of the disease. So positive predictive value will be low if the disease is very rare. In order for the test to be diagnostically significant, it should have a high sensitive and high specificity, more than 90%. So let us do some mathematical exercise together. We have a 100 cases. 50 cases are true patients and the other 50 are healthy cases. A test done for the 100 cases and where the test was positive in 50 patients and was negative in the rest of the patient. So what's the sensitivity of the test? The test is 100% sensitive and also 100% specific for the test. So the test is accurate 100% in diagnosing the disease. So a test with this feature is appropriate for both screening and final verification for the disease. On the same cohort, if the test result was positive in only 25 cases and negative in 75 cases, so since the sensitivity of the test will be 50% and the test is specific in 100%. The accuracy of the test is 75%. So this test is not suitable for the screening purpose, but is suitable for the final confirmation of the disease. In the same group of patients, if the test result was positive in 7,500%, so we have almost 25 cases who were false positive test, and negative in 25%, so the sensitivity of the test is 100%, but it is specific 50%. The accuracy of the test is 75%. This test is good for screening purpose, but it's not suitable for the final confirmation of the disease. At this point, we all agree that there is an absence of gold standard in rheumatic disease in comparison to other diseases which have a confirmatory test to rule in or rule out the disease. For example, diabetes mellitus, we can be 100% sure that the individual doesn't have the disease if hemoglobin A1C was normal. In rheumatic disease, laboratory markers are not positive in all patients. Furthermore, they are abnormal in some normal population. So the individual patient who have a pathognomonic clinical feature of the disease has a 100% probability of having the disease regardless of the test result. In the rest of the presentation, I will go over the most commonly used rheumatological labs. The first group of molecular biomarker is the measure of acute phase response, and it belongs to the descriptive biomarker. The most commonly used one is the ESR. ESR is non-specific but sensitive for most type of inflammation. It doesn't say anything about what caused the inflammation, whether it's infectious or paraneoplastic or rheumatological cause. ESR is less than ideal for monitoring the disease and the treatment response for two reasons. ESR always lag behind the resolution of the inflammation. The second reason is that if the treatment is started and ESR dropped and increased again, it might be due to the disease flare or due to the infection in the body. ESR is suited for screening purpose, but is not suitable for the final confirmation of the disease. The second biomarker is a C-reactive protein. This biomarker is non-specific but more ideal for monitoring the disease, as the CRP could fall within 1 week from resolution of inflammation. CRP and ESR values tend to correspond with each other, exception in some rheumatological disease like SLE, juvenile dermatomyositis, and polymyositis, in which CRP is usually normal or minimally elevated unless there is an infection or serositis or arthritis. Serum amyloid level is considered as an acute phase reactant, but this test is not routinely used to monitor the acute phase response because it's an expensive test and due to the technical difficulty in performing the test. Normally it's below the 3 milligram per liter. Serum level of serum amyloid and CRP are usually correlated to each other. One specific indication in measuring the serum amyloid is to monitor the response of colchicine in familial Mediterranean fever. In comparing these three acute phase reacting, the ESR easily measurable and it's a cheap test, but it has a disadvantage of it can be affected by age and gender. It can be affected by the anemia. It responds slowly to the inflammation and lag behind the resolution of the inflammation. And it can be also affected by the most commonly used drug in rheumatology, like the glucocorticoid. The CRP, it rapidly responds to the inflammation, rise within 4 to 6 hours, and it's unaffected by age and gender, but CRP is non-specific. Serum amyloid correlates better with the CRP and has a rapid response to inflammation, again unaffected by age and gender, but it's a very expensive test. There is an article published in 2020 encouraged the use of serum amyloid level for detecting subclinical inflammation, an indicator of response to therapy, and for monitoring disease activity. I tried to summarize some observation from this article. One observation showed that serum amyloid level has higher sensitivity and specificity than CRP and ESR as a marker of disease activity. We could have an increased serum amyloid level despite having normal level of CRP and ESR, while an increased CRP or ESR level with normal serum amyloid concentration are extremely rarely observed. Persistent elevated serum amyloid values are associated with development of life-threatening complications like secondary amyloidosis, pulmonary involvement, and coronary heart disease. The first biomarkers, which belongs to the mechanistic biomarkers group, is antinuclear antibody. Antinuclear antibody is overused as a screening test in pediatric. It has low specificity and sensitivity. In this graph, we have 2,000 people who have ANA test done for them. Only 200 people will have a positive result. Only one out of these 200 people will likely end up having lupus. So positive ANA test itself is not diagnostic of SLE, but can contribute to the diagnosis of SLE in the context of other signs and symptoms suggestive of SLE. In a nutshell, ANA can be used as screening test in children only to answer one diagnostic question: does this child have systemic lupus? And a negative test certainly is reassuring. Another biomarker, which is anti-double strand antibody, it has high specificity for SLE, 97%. It is more sensitive marker for this disease than anti-SM. Anti-SM is a type of ENA antibody, which is specific for SLE but has a low sensitivity. Anti-double strand antibody associated with increased risk for development of lupus nephritis, and it can be used as a disease activity measurement as its level fluctuates with disease activity. Now, the most well-known biomarkers is the rheumatoid factor. Rheumatoid factor is IgM antibody against the Fc portion of IgG antibody. It's a standard assay for screening for rheumatoid arthritis in adult patients. But 10% of healthy adult individuals will have a positive rheumatoid factor. And also, patient will only seroconvert after having the clinical disease for weeks or months. In an established rheumatoid arthritis, rheumatoid factor has a sensitivity of 85%. In early rheumatoid arthritis, the sensitivity is approximately 50%. Higher titer of rheumatoid factor are associated with more severe disease and with a greater risk of extra-articular disease. But rheumatoid factor can't be used as a longitudinal measure for disease activity. Most children with positive rheumatoid factor test don't have juvenile idiopathic arthritis, and most children with juvenile idiopathic arthritis don't have positive rheumatoid factor test. Anti-citrullinated peptide antibody, the anti-CCP. It's associated with rheumatoid arthritis, but may also be a valuable marker only in the rheumatoid factor positive polyarticular form of juvenile idiopathic arthritis. They have a high specificity, 95%, and its sensitivity is as a rheumatoid factor. Anti-CCP can be as a screening test, as anti-CCP antibody may occur long before the onset of symptoms, and also can be used to direct early and maybe aggressive therapeutic intervention. The last biomarker for today is the ANCA antibody. ANCA antibody is the hallmark of active ANCA-associated vasculitis. ANCA are present in all patients with severe ANCA vasculitis and 80% of limited disease. Titer tend to fluctuate with disease activity. ANCA has a positive predictive value of 54 and negative predictive value of 99, but a negative test result does not exclude ANCA-associated vasculitis. I want to go over two interesting studies that highlight the significance of ANCA testing. One study done at Uppsala Hospital University in Sweden. It was a retrospective study of medical record of all patients with ANCA test positive between the year 1992 to 2002. At the time of running the test, out of 74 patients, 56 patients had a vasculitic disease, and the other 18 suffered from another heterogeneous group of medical condition. These 18 patients who didn't have a vasculitis at the time of running the test, their diagnosis was re-evaluated through June 2006. None of these patients ever developed vasculitis. The other study was also a retrospective analysis of 2,700 samples submitted to the laboratory for ANCA testing over the period from 1996 to 2000. Those samples was submitted from different hospital department from neurology department, general medicine, rheumatology, and respiratory department. And the result of the analysis showed that the general medicine was responsible for the 92% of ANCA requests, followed by the neurology and then the rheumatology. And the majority of patients with positive ANCA, about 88%, didn't have a confirmed ANCA vasculitis except in the rheumatology department. The points we're taking from these two studies are ANCA testing on a population should be only done when a reasonable clinical suspicion of vasculitis is present. And the correct utilization of rheumatological lab is positively correlated to the time spent in rheumatological residency. So we should know when that labs do matter. Rheumatology labs are often less diagnostic than they are confirmatory. Our base workup is more reliable in suggesting severity of disease than the specific rheumatology lab. For example, a complete blood count with differential in a child with severe musculoskeletal pain and refusal to walk may provide the diagnosis, as frank arthritis are common presentation of children with leukemia, so CBC is more important than the rheumatoid factor here. The hypertensive young woman with skin thickening and rhinoid that cannot complete a sentence talking to you is an emergency even if the ANA is negative and ESR is normal. So, to conclude, there is no screening test of rheumatology. In nearly all clinical settings, serology is confirmatory to index of suspicion of disease rather than diagnostic by its own right. In most clinical settings, non-serology play a greater role in acuity of care than any of the rheumatological labs do. When approaching a patient suspected of having a rheumatological disease, Consider the clinical picture. If the test was requested in the absence of a clear indication and that result is positive, do not attach a diagnostic label prematurely. None of the tests can confirm or exclude a condition. The take-home message is to trust your clinical impression independent of labs. Thank you for your attention and Ramadan Mubarak.